Good afternoon, everyone. Thank you for joining us for, I believe this is the fifth weekly New Hampshire COVID Alliance Zoom meeting. We appreciate your attendance. Have a lot to discuss today with guidance out this past weekend on Phase 1B. We have Dr. Chan and TW Hall here to discuss this more. Thank you both gentlemen for participating. Again, we're just going to go real quick through, if you haven't participated in this, our mission here is to convene stakeholders in New Hampshire to promote the vaccine confidence, support accurate and consistent vaccine messaging, and to foster coordination of the state's vaccine allocation. We're going to do this to promote public buy-in to help increase immunization rates. Most importantly, we're going to try to act as a force multiplier to support COVID vaccine communication and allocation plans of the Bureau of Infectious Disease Control immunization program. We'll also get into probably also trying to counter some of the misinformation and then help promote use of New Hampshire's immunization information system. Next slide, please. So a real quick, again, if you are moderate or any category under 1A, under 1B, you'll be going through and you'll be asked to register. If you're having problems, and I just helped a practice today literally get through, so if you're having problems, you have sent in for information, you're not getting a response, please email me directly and we will get you signed up one way or another, as we did an entire practice today. You should be able to use the VAM system now to schedule second visits for those that opened up last week. Next slide, please. And all this information, as we mentioned before, can be found on the department's COVID vaccine information site. There's a URL. Also in that site is the summary of the allocation plan steps. That's been updated to the 16th to incorporate the 1B. In addition, we'll talk about the next hound that was just out this weekend. For those who are interested in volunteering to give COVID vaccinations, please respond to NH Responds under, and the pulled tab is COVID-19 teams. We know the information hasn't been real good back at confirming that, and we're going to try to work, continually work with NH Responds. The other information that I've been giving out is for you to suggesting calling your local public health network and tell them that you're interested. And so that's worked in a couple instances. Next slide, please. So real quick update, most recent HON notice is 34B. And why it's B is because we changed the methodology, how to submit to either the single person form or the multi-patient Excel spreadsheet to a secure FTP site. There's also instructions how to do that. We're asking practices who have medically vulnerable patients to please upload this information to that site as early as possible this week. The closer you get to the 22nd, the more likely that there will be a delay in getting those folks in. Last thing we want to do is really put these medically vulnerable to the back of 1B. So please get that information in as soon as possible. Next slide, please. Again, there's two ways to do it. There's a multiple patient referral form as an Excel spreadsheet. It's one-stop shopping. You go in there, it has the FTP site on it. It also has the attestation information that you'll need to complete on that. So if they have any problems with your list, they can get back to that particular individual. What we're also recommending is follow-up steps. Once you do that, please get this information up into your EHRs so that you can ensure appropriate practice coordination. It's important that your staff and you be on the same page as you're moving forward, and that you have submitted their names to the division to be uploaded. The second thing is um, let these folks know that you've at least sent their name in, and we'll talk a little bit more about the process of what happens once the division has this information. Last slide. And again, just thank you to our sponsors, Harvard Pilgrim Health, Anthem, Blue Cross Blue Shield, Dairy Medical Center, Primary Care, Convenient MD, WellSense Health Plans, and NH Healthy Family Plans. All right, at this time, we'll take, and why don't we start, we're going to talk about two different things. So I think what we'll do is focus first on, since we have Dr. Chan here, about any questions that you may have about the medically vulnerable populations, any interpretations on the information. Again, on the vaccine information website, there is information that goes into more detail than the initial information sent, and gives some descriptions and whatnot. Ultimately, you do have, as practitioners, you do have some leeway here, as been communicated by the governor. So we'll be happy to take your questions. Ben, do you want to kind of just give an overview of the medically vulnerable guidance?
So I don't know that I have much to say. I will say that this is a work in progress. People can find the guidance online and through our Health Alert Network message. The phase 1B prioritization first prioritizes people 65 years of age and older who are more vulnerable to severe COVID-19. Then there's a list of medical conditions listed so that if people have 2 or more of those medical conditions, they can also be prioritized for vaccine in phase 1B. That list of medical conditions is not meant to be all inclusive or exhaustive, and that list primarily is taken from the CDC website for people who are at increased risk for severe COVID-19. And so it points you to what we currently have on our website, as well as the CDC website as well. What I will say is that there's, as we have done with phase 1A prioritization, there is a technical document that is in the works to help clinicians interpret the summary that's currently there and to clarify certain points. So for example, in the comorbid conditions that are included in phase 1B, when we talk about other high risk pulmonary conditions, what does that mean? Does that include people with cystic fibrosis, or, is it just people with COPD? What about people with, idiopathic pulmonary fibrosis or other, chronic lung conditions? And the short answer is that, yes, we're looking at, interpreting some of this guidance in a more inclusive, comprehensive way, but there's another technical document that's coming that will provide more detail on this. And so stay tuned, and I would point you to that guidance document when it becomes available. The last thing I'll note is that I do have to drop off at 12:30 for another meeting that I have. But TW, I believe, is going to be on for the entire call and is certainly leading the charge here when it comes to all aspects of COVID-19 vaccine. Thanks.
Dr. Chan, one particular set of emails that we've been getting from practices and from patients and patient groups has to do with neurological conditions that aren't in that first tier of guidance. Any direction on those who have one condition and then have a neurological condition that's advanced, such as Parkinson's or dementia or Alzheimer's? Any recommendations on clinically how to approach that?
So neurologic conditions are not listed in the current list of conditions that are to be prioritized. As with anything, clinicians have the ability to use their discretion to refer people for COVID-19 vaccination if they believe that a patient is at significantly higher risk for severe disease and increased morbidity and mortality. I think the bottom line is that we're focusing the prioritization on people that are at higher risk for hospitalization and dying from COVID-19. right? So when you're talking about neurologic conditions, that's a very, very broad category. And many of those people, especially if you're talking about dementia and other neurologic conditions that oftentimes, not always, but oftentimes are associated with age, will be picked up in the age category. So, you know, you're right that neurologic conditions are not listed as one of the broad categories by which we're suggesting clinicians prioritize patients. But if there is a patient that a clinician believes is at significantly higher risk for severe COVID-19 and hospitalization and death, then it's within the clinician's ability to still refer that patient for COVID-19. But we're not broadly recommending that neurologic conditions be used as prioritization.
Thank you very much, Dr. Chen. So let's turn to TW, give you a chance to kind of give a broad overview of 1B, what you're seeing up to this point.
Thank you very much for that. So good afternoon, everyone. Appreciate you guys taking time out of your busy days to coordinate with us and work through it. And please let me say thank you very much for all that you do to keep the citizens safe here. What I'd like to do is before I get into 1B, I'd like to just take a step back and walk through the events of last week a little bit, try and dispel any rumors that are going around or whatnot in terms of allocation. I know that my federal counterparts did not do a great job this last week in terms of how we were disseminating information, and so it kind of came out in fits and bursts, and so please accept my apology on that. Let me start with that. So as those of you know, Secretary Azar last week came out and basically said that there was this wave of vaccine that was basically going to come to the states, and the state processes were kind of slowing it down, and really we just needed to open up and put the pedal to the metal. So a couple of things out of that. The first thing that I'll say is that thanks to all of you, thanks to the way that New Hampshire has been able to group together, we truly aren't in that category. We're one of 2 jurisdictions that move through our allocations at a very quick pace. We don't have doses sitting around collecting dust, and we're constantly modifying our processes, as you'll see in 1B, so that we are not putting doses just away somewhere. We are trying to get them shots in arms, so to speak. That being said, there's a balance act with this, and so while our allocation and our distribution is designed on quick throughput, we also recognize that there's a percentage of our population that's not going to serve well, and so there's a 10% equity holdback starting with 1B next week that will be held back to account for groups that are defined as these medically vulnerable groups. When I say medically vulnerable, let me be clear. I'm not talking about the 2 or more comorbidities. I'm talking about being vulnerable to COVID because of economics, because of race and ethnicity, because of all of these other parameters that we're tracking and working through. So there's about 5 or 6 different vulnerability scales. There's probably a lot more than that. And so bringing those all together to try and see where our greatest areas of our inequity in our state, and then trying to work around that, as well as pushing a lot of vaccines through, is a key part of our strategy overall. So I just want to say that as a couple of different grounding points. Unfortunately, our state gets about 17,000 doses of vaccine each week, and that is not changing anytime soon that we have been messaged from the federal government. So for those of you that saw that Secretary Azar kind of walked back or recanted his statement, unfortunately, when he did that, he also made it seem like there wasn't second doses that were going to be available for people. That is not the case either. There are second doses that are being allotted. There are second doses that are being available. There is no plan at this time from the state level to prioritize first doses over second doses. So again, we're moving forward with the same plan that we have in place. We want to go through our 1A population. We want to get those vaccinated. We want to get those people the second doses. We want to make sure that that occurs. And we want to move on to 1B category and move from there. Now, go ahead.
Yeah, there's one of the biggest questions that there's actually two big questions, but the first one is, okay, now that you're getting these uploads of patients who are medically vulnerable, what are the next steps? What can patients expect? What can practices expect as a follow-up? Are they going to be notified? How is that going to happen? How are they put on the list, or how do they register or or schedule?
So thank you for that. So when we get into our 1B category, where really that's where you're uploading these information to, right? So let me talk about the 1B schedule, and then I'll go back to Jim's very specific question in terms of what the patient experience is of that. So the first thing that I'd say is that we've got a few different categories for 1B, right? As Jim mentioned, Dr. Chan mentioned already, in terms of these different categories that are coming through and what we're doing. So 65 and older, they don't need a note from any doctor. They don't need anything else. They qualify based on age. That's it. Now, how do they access it, right? So let's talk about two different carve-outs. Let's talk about first specifically what Jim said in terms of the expectations for your patients once you move that forward. So let's take that first, and then I'll talk about the general population and their review next. So first, I would say in terms of in terms of your patient population, when we get that list from you, then what we're doing is we're turning around and sending out communication to them. That's going to happen in one of two ways. Either we're going to have to make a phone call to them because they don't have the technology with the email and things like that. We don't get that. Or we're going to reach out through email. One of those two ways is how we're going to access them. So let's take the email path first. When they get that email in, we are going to ask them certain screening questions. And we have to do that because we recognize that your role out there is to say, hey, they qualify. Our role out there now is to then go through and say, okay, but do you have allergies, specific allergies that would make you not able to get this vaccine? Have you had a vaccine in the last 14 days? Have you had the monoclonal antibodies in the last 90 days? You know, all of these different cards out, right? So we need to get that data from them to make sure that they're eligible. Okay, so there's a couple of different ways that data will go. Either they're not eligible, plain and flat, they're just not eligible at this time with what we know, right? They are, the next carve out will be those that are eligible but need to have a time delay, right? So you're eligible to receive it, but it was 14 days since your last vaccine. So let's wait those 14 days, or let's wait the 90 days for the monoclonal antibody therapy to finish up before we do this for you. The last way that this could occur would be those that are the what you call in the IT business soft stops. So they're, hey, I'm pregnant. Well, you should really have a conversation with your healthcare provider to make sure that you understand the risk versus benefits before you come to us, right? So that's those kind of soft stops. You know, I'm immunocompromised. Is this right for me? Those types of things. That is where you may get a feedback loop that would come back to you as providers. And you would then say, yes, hey, I didn't realize you were pregnant. You're going to an OBGYN, you know, you haven't followed up with your PCP, or all the other variables that we all understand happen in real world experience, right? So then you have that conversation with them, you come to that shared decision making with your patient, and then you move that forward and you say, okay, so you know, the patient says, yes, I still want to get vaccinated. They still have that invite, they still get right back in, they go in and they then get that invitation out. So now they're getting an invitation from the email that we have here to come in and register at our site. That's one way to do it, right? And that right now, that's the VAM system, and we're moving with the VAM system for right now forward as we start 1B. We will have a gradual transition from the VAM system to the VMS system. And the VMS system really, just so that you all are aware, it's the same builder. The difference is that we can make it New Hampshire specific. So we can take some of the pain points of VAMs and we can turn that around and we can modify that in the VMS world. So once, for right now, with the schedule as it goes through, right? So right now they either get that email and they answer those questions, or they have that telephone conversation in which they ask those questions. Out of that, again, there might be a feedback loop in which they say, you know what, I need to hold off. I need to have a conversation with my PCP. And then once they've had that conversation, they still want to get it. They come back in and they say, either through a telephone call or whatnot, right? I'm ready to have it. I want to have it. or through an email they generate saying, hey, look, I'm ready to have that now. They submit their stuff. So at that point, if it's a telephone call, they then can walk through and get scheduled. And in that telephone call, depending on who that person is and what their technology capabilities are and everything else, more than likely we will set up their first dose and their second dose appointment at the same time, because of the fact that we don't know if we're going to be able to get them again, right, or things like that, right? So there's some possibilities in there. We also, and I want to be clear on this, that this particular part of the strategy is what we're still gaining through right now. So there's a second option in which we have them call back, and we're working through gaining that out for this Friday and what that looks like. But those are the two options for actually getting them scheduled. And it would be just like, you know, I'm calling in and look, we went through all our list of questions. It looks like you're all good to get the vaccine. You know, I've got an appointment at this address at this time. Can you do that? So that's how they would get that through there. That's how they would get that. That's how your patients would get that invite initially through VAMS, right? And they would get an invite through VAMS, and then eventually they get that invite through the VMS system.
So very similar to
Jim, you're on mute.
Very similar to
talking.
So it's very similar to what healthcare workers did with the qualifying questions. There's about 5 or 6 of them, and then rolling through. So all these patients who, in short, who you put on or recommended as medically vulnerable will get an email from the division or through VAMS, basically, you know, asking them to then pre-register and then go schedule. I just wanted to touch with Dr. Chan. See, you've seen some of the questions and whatnot. Is there anything you wanted to say before you had to leave today?
No, the only thing that I'll say is that some of these questions, you know, we can't answer, or we're not in the best, you know, position to answer. I've seen some questions about the National Guard, about, you know, clinicians volunteering and indemnification, and, you know, so we don't directly oversee what's happening with the National Guard, and you know, we're not lawyers, and so if people are interested in getting involved in the vaccination efforts, you know, I would suggest reaching out to your local organizations, whether that's a hospital or, you know, the regional public health network representatives, and seeing how you can volunteer and be involved. We always are looking for more people to be involved in public health activities like vaccination. But some of these legal questions that may come up around people volunteering their time, you know, would require further sort of vetting and assessment of how the person is looking to volunteer and with which organization, and whether it's through the state or local hospital, and would point you to sort of the more legal expertise side of this response.
Dr. Chan, thanks for joining us today. As always, it's much appreciated, and we'll come back, TW. One of the, again, questions that we've been getting from multiple practices that are on state boundaries is that they have residents, or they have patients that are actually residents of the other state. And the guidance has said you kind of have to be a New Hampshire resident to be vaccinated in the state. Can you just confirm that? Is that?
Yes. So unfortunately, you can tell where my sympathies lies, because I'm going to say, unfortunately, yes. At this time, that is the guidance that's been determined at our highest levels of our government. So if you feel strongly about that, I encourage you to reach out through your organizations to try and affect change. But right now, that's our marching orders.
All right. The other option that we have, and over the weekend, I have reached out to the public health departments in both Maine, Vermont, and Massachusetts, and my counterparts there. And what we're going to try to do, so what I would recommend to practices who have patients across the border, particularly the 1B patients, gather those patients up into the multi-patient spreadsheet, and hold those, and we'll give you specific information. But I think what we're going to do is try to set up specific either FTP sites or URLs, someplace where you can go and share that information securely to that other state. So say you're up in Fort Smith and you have a number of patients who would qualify as medically vulnerable, still document those in a separate Excel spreadsheet. And we will try to get you information so that you can get that information to the public health officials in Maine, and they can be treated in the 1B category there. So again, we're trying to do it with all the neighboring states. We realize that this is kind of an issue that's moving forward.
Jim, if it's all right, I would like to just talk about just two other general strategies before we get into specific questions, if we could. So the first thing that I would say is that as we go into the 1B strategy, and we're looking at that, I define the way that your patients would access this for medically vulnerable. I do think it's helpful that you understand how other groups will access this, because if you have 65 and older, you want to be able to tell them that they don't need to wait on a list and things like that, that they can call directly in, right? So they can call directly in if they're going to have problems with technology, and that call center is going to be stood up by this Friday. So we have, we have now, I think 130 staffing that call center, 2 shifts. We also are expanding that out on a Monday through Friday basis to, I think, include 250 additional folks trying to do this. So know that we're trying to push out resources to accommodate that, because we recognize certain groups are not going to be technology friendly. The other thing is on Friday, we will have that open website where they can go in, and if they're 65 and older, or any category that does not require this medical attestation, grouping coming from you all, they can fill out that form, and that will then kick them directly in the pool to get the invitation out, and that'll actually speed up the way that things happen. So just want to make sure that you all understand that. Once VMS is up and running, there's actually not going to be a pool that they land in before they get an invite. They'll go straight from filling out that form, and they'll come into VMS, and they'll be able to schedule things directly in there. The other thing that I wanted to share is that when we talk about vaccine coming in and the amount of doses that we have right now, we are not going to be able to support closed pods right now. We're just not. There's just too little of vaccine coming into the state. And so what that means is that means that we are asking those that have the capability of doing open pods to help us out in that endeavor. Now, let me talk through that for just a second. Right now, I have 17,000 doses coming to the state. I got 13 fixed sites. I got probably about half, maybe a little less than half of the hospitals right now at this particular moment, because this just changed, right? This guidance just came out, so people are still processing it and seeing what they can do in terms of their resources, but saying that they can open up their own open pods. I also have 139 pharmacies that have agreed to stand up and vaccinate as a part of their process as well. So we have providers out there in the community that are willing to do open pods with us. What we need to do then as we move forward is we need to figure out, okay, how do we open up those open pods, and how do we do this in a measured way so that I'm not sending you a message, hey, I need you to open up, but I can only give you 20 doses, right? I want to have a conversation. We need to have a two-way conversation with those that are opening up. And how this would look then is, as we stand up more open sites, people see that in VMS and VAMS. So in order to be an open site, you have to be willing to use the VAMS and VMS system, so that again, those people coming in, regardless of where they're a patient at, they can go in through one site, one portal, sign up, and go from there. And so those open sites would then open up. So if I was running my own clinic and I said, hey, I want to do this and I'm willing to be an open site, I'd fill out the provider agreement, right, which many of you have already done. And once I filled that out, then there will be a survey coming out to those of you who are not a pharmacy or something like that, that we know, or an urgent care or something like that, where you don't have a patient population, right? So we know that you're going to be an open pod, so to speak. When we have that, we're going to need to have a two-way conversation with you to talk about that. And then we'll want to turn you on in a very strategic manner. We'll want to make sure that you have time to build up the resources or allocate the resources for it. And then we want to commit to a number of doses with each one of our open sites as we do this, so that you can expect for that for the time frame that you wish to be involved. So it's a very measured approach with the open pods and opening this up, and I just want to communicate that for those of you that are out there. So if you've submitted a provider agreement already, expect that we will be sending out a survey to those of you that are in it as to whether or not you'd be willing to have an open pod or not. And then we can have a further conversation as we get more vaccine.
Great. Thank you, TW. Just as a side note, there's a little bit, we're seeing some kind of variation on the same theme, but we have a hospital system that doesn't believe that it can adequately do mass vaccine on their campus. And what they're doing is they're partnering with a Fortune 500 company nearby who has the space, has the facilities, can do a drive-through through a garage, and is willing to do that. And that's an innovative way to approach this. So the hospital is already receiving vaccine; it'll be already kind of part of the list. But this allows them to take up, a broader strategy, knowing that they can't really do it adequately on their campus. So we want to try to encourage those kind of joint arrangements, working with other community partners to increase kind of throughput. What I've been telling most individuals about volume is twofold. One, the Biden administration is going to put some mechanisms to try to increase production of both Pfizer and Moderna in the short term. They've been working on that to essentially get more production capabilities out there. That will happen, but still, even gearing those up will take another month and a half to 2 months. The other thing that is, I believe, both the Johnson & Johnson and the AstraZeneca vaccine candidates are trying desperately to get their emergency use authorization applications in by the end of the month. But even if they kind of follow the same kind of timelines of the first two vaccines, I think you're looking at 2 to 3 weeks just to go through the process to get the approval. And then secondarily, you're looking at, I think, at least at the same time period to essentially generate production, get it out to the federal distribution channels and move forward. So I think realistically, if things are going well, then perhaps sometime in March, don't know when, but sometime in March, we could see that vaccine supply come in greater quantity to the state. So the one thing that I'm going to try to share my screen on this real quick, has to do with low risk workers. And so I've just hopefully put up on the screen something that shows you the list here on the lower risk. But go back and look at the 1A guidance from late December. And it has all the most risk, moderate risk, and lowest risk patients in this particular category. And so from that, you can kind of make a determination of do your employees in a healthcare setting kind of meet these. But this is a quick risk, but it's basically everyone who's not in, it would be incidental patient contact, not direct as healthcare workers would be. I hope that's helpful. That's a question that often comes up. The other question, kind of the theme on the out-of-state individuals who want to get is what we call the snowbirds. And so these are individuals who maybe spend 100 days in Florida, and actually some of them, for tax purposes, may have their ID shifted or a driver's license. How best to handle kind of the snowbirds?
So a couple of things out of the statements that you made, and I appreciate those statements, Jim. First, I would say that we are coming out with 1B technical guidance, and so anticipate that coming out later on to try and help people, just like we did with 1A, so that will also assist in different areas. 2, your lowest risk health workers, if you can get them start to be signed up this week, that is absolutely okay. So go through and start to take care of that. Now you can do that through the fixed sites and whatnot with the healthcare workers and whatnot. I don't believe the form has a lowest risk health worker category on it as of yet. We'll be working to change that, but feel free to go through list them as moderate or whatever the option is for healthcare workers to make sure that they can sign up and get vaccinated. I would suggest that you do that before Friday because all of our available appointments obviously are going to come out to a large bulk of people. So definitely take a look at that. The last thing that I would say is that when we are moving forward with the 1B allocation and the snowboards and things like that, what we're doing is we're basically taking the list that allows for proof of residence by DMV, and we will be pushing that out in our frequently asked questions. But it's basically all of the things that DMV allow for to show that you have some sort of residence up here. So it's anything from a title to a bill in your name at a New Hampshire address to a variety of different other things. And that's how we will verify. We are adding one category to that, and that's in a nod to students who have been assisting in vaccination efforts and other medical care, but are not residents of our state. So if they get a letter from their school stating that they are in school here and they qualify for 1A, right, in terms of being a healthcare worker or a nursing student or something like that, then they can get vaccinated as well. So those are the different ways that we're trying to address snowbirds and some of the other areas in terms of New Hampshire residents.
Right. Just a couple clarifying comments. We can both try to take this on, but essentially, vaccine is only going to be distributed, at least in the early stages of 1B, to existing sites, either a hospital or one of the state fixed sites. So while you may have signed an agreement to be an open or a closed pod down the line, there's just not enough vaccine right now to spread it kind of that thin. And until we get some more vaccine through, probably won't be moving to those provider agreements until there's more vaccine at this time, or there's another evaluation down the line of how we're taking on 1B. And the second thing I just want to mention, I think I might have confused some individuals. If you submitted names of patients to the division as medically vulnerable, we're suggesting that you contact those patients either by email or by phone, just to let them know that you've submitted their names, because you'll probably lessen phone calls coming directly and say, hey, I think I've got these conditions. So I think it's prudent for you to reach out and say, yes, we did submit your name, and you should be getting a communication back through VAMS to pre-register for your vaccine appointment. So those are just a couple of clarifications as we've seen.
And Jim, if I can make two statements off of those. To your first comment about opening up, there is going to be some times where we might reach out to a couple of you to do different things and to open up and things like that because of where we're at, right? So we're scaling what our limited vaccine is, but for example, we also recognize, we want to give people choices. So if a hospital network says, look, I really don't have the resources to do an open pod at this time, then we would be looking at other partners in that region to do that if we can't handle that volume through some of the existing provider agreements and some of that stuff. So please understand it's a work in progress. We are looking to try and expand this in such a way that we create as many options in the right locations that we can for open sites. So again, having a wide lens in terms of where that is, population density, vulnerabilities, all that sort of stuff, to try and do that. And so please understand that in terms of that first area of as we expand or as we shift from closed pods and just the hospitals receiving vaccine versus how we expand in other ways. The second thing that I would say is that we would ask that, as you're submitting data to us, these people are not going to get a response to us, response from us until starting on the 22nd and beyond. And so please set that expectation as you're communicating out that we're not going to be able to reach out to them ahead of time yet, as we're working to try and get this all lined up for starting on the 22nd.
Good information. Good. There's some question on the tail end of the process. So the question is, when will there be more information on how we can the vaccines for documentation? So I guess it would be the New Hampshire IIS. When will more information become forthcoming on that?
So it depends on how you mean in terms of documentation. If you mean permanent record of vaccination, that is the IIS. And we are looking to stand up a public portal for that so that patients could go in and directly access their vaccine information. In order to do that, they are going to have various pieces of data: their first name, their last name, their email address that was used for this, access point, and their date of birth. And so you can automatically see not everyone has an email. So we're working through and gaming through what that looks like and sending out guidance on what that looks like for if you don't have an email, or if you've done this through telephone wise, what that is to try and access that. The second thing I would say is that as we stand up the IIS, we will be giving out classes on how to use that system and whatnot, get providers in there so that you can query and go through databases and things like that yourself. So know that those two processes are coming in terms of that. In terms of direct documentation, right here and now, so to speak, that is where we're leveraging VAMS and VMS to document that experience, and then those systems are then feeding the IAS for the permanent record. So that's how that data flows.
Great. So we have a little bit of kind of a reverse question about the converse. What if you have a New Hampshire resident, but they're a physician or primary care provider is out of state? So we have been sending information to all licensees. And I think it would essentially work the same, even if you're an out-of-state practitioner, but are a licensee of New Hampshire, then we would have you send those medically vulnerable patients who are New Hampshire residents through the same two systems to the FTP site.
Affirmative.
Okay. When people, here's another question. When people register for Group B, will couples be able to register together to get appointments at the same time? Couples or caregivers. So I've heard this where I have a mother who's 85 and I'm over 65. Can we get the register for the same time window?
The short answer is much like when you go to do it on your phone for a movie theater. We don't have the technology to do it directly at the same time. And so what that's going to look like is if you're both calling in terms of a telephone together, right, or a telephone experience where you're trying to schedule it together, then the person on the other end of the telephone will try and schedule those two times as close together as they can. Likewise, the same thing for the couples. When you're looking at the email invite and the scheduling of that, then you have a couple of options. You can either go on, two separate computers at the same time and say, hey, look, I've got an appointment open, at this location at 10. Okay, I see one still open at 10, and try and select those in real time together. The last option is you do it with one, you set a time for 10, you try and look at the time slots and make sure that there's openings on either side of you. And then you schedule, you use the same computer, you open it up and you try and do it at the same time for the next time. All of those are imperfect systems for that. I fully recognize that, but unfortunately you can't schedule two patients at the same time with the equipment.
Right. So here, if a patient, if a practice essentially sends their vulnerable patient list, and that patient doesn't receive an email or a phone invitation as we kind of head into a 22nd pass, what should they be doing, or how can we assist them?
I'm sorry, forgive me, Jim, I missed it. Say it one more time.
Okay. So if a physician's office, a PCP, has given the division a list of individuals and they don't get a response on email or a phone call from the state, what should they do next if they know that they've been put at least on a medically vulnerable list by their PCP?
So the first thing that I would say is we recognize that as a state we're taking on a lot, and so we recognize that that's how we're, that's right now with our limited doses. We recognize that that's that challenge. The one of the ways that we're trying to work this through is by setting up expectations of response times back to them. So if it's taking us within 5 days for them to get that response or things like that. So try and communicate out to our external stakeholders, you guys, as well as general messaging of this is our time frame. We should expect that we see something within this time frame. That being said, if that time frame has elapsed, right? If we're now not meeting that, we're not talking about not meeting it by a couple hours, but we're talking about not meeting that for like a day or two, or a longer period of time, then we need to hear that feedback and we need to then set up a way to figure out what happened. Was that a email typo error that occurred for that patient, and that patient isn't getting that response because that email is not going out? Is that because the spam filter is catching it on their email response, and so therefore they're not getting it? I will say that we have found that work emails do not do well with our processes, and so we have had a few different times where it wasn't in the spam filter. It was that the organization. Sorry, I don't mean to chuckle, but the organization had blocked DHHS or something like that as a site, or had blocked VAMS as a potentially malicious site or things like that, and that we can't do anything about. So I would encourage you, first, use personal emails as much as you can for that, because I think that cuts down on that organizational filter thing for the emails. And then we need to have two-way communication about that. And so being able to allow you to call in, or someone from your staff to call in about a patient list that hasn't been taken care of, we need a way to reconcile that on the back end. So more to follow on how we set that up.
Great. Just a couple of clarifications to questions. So we've been talking about primary care practitioners submitting. This can also come from a specialist if they, you have patients, say you're an orthopedic surgeon and you have patients that meet, two of the criteria that's listed in the guidance. So it can come from any practitioner, a specialist, or primary care. We're just using it in general terms. The second is more of a hypothetical. If the practice wanted to vaccinate their own patients and therefore not willing to submit names of medically vulnerable patients to the state, the bottom line answer here is then they would wait. They would wait to some other time that they would potentially qualify down the line. So medically vulnerable is what we're trying to do, is get them. We know that the basic premise of what we're trying to do is those who are most susceptible to death because of COVID. So it's that risk-based system that we're really trying to front load and get those patients through first, those being the medically vulnerable. So no, you don't have to, but you're essentially putting them back to later categories, which could be, given the supply, could be months from now. So we're encouraging you, if you, while it's not the best solution, again, if we had adequate supply, we probably want practices, vaccinating their own patients, particularly if they have a number of different comorbidities. That's not what's happening. We don't have that. This is not the best system. So we're urging all practices, if you have patients, let's try to get them in line as soon as they can. We'll figure out ways if they can't get to the vaccine. I mean, there's a lot of options, but if you're waiting for 2 or 3, 4 months to do it yourself, then those patients are going to be much more vulnerable to death or hospitalization. That's why we're really trying to push them right now. Is that correct? Or is that what you would?
Yeah, no, I appreciate those comments, Jim. I would love to just give you all vaccine. The number of vaccinators that we have is in surplus of the vaccine that we're getting in, and we are unique in that perspective in our state. There's other states where that is not the case, and that's creating some of the vaccine holdups that they have. And so please know that we definitely don't want to control this process for any longer than we have to. We definitely recognize that there will be an eventual turnover to practices and whatnot. We just have to get through a couple of things. Some are the points that you're bringing up, but also the variability, right? Different people have different resources and different practices have different resources. Some have the ability to do this and are hard chargers and ready to go. Others don't. And so that's the other scale of this, right? Is recognizing our community that's out there has various capabilities of doing this. And we want everyone in certain categories to try and be vaccinated as quickly as possible. That means that we have to work with everyone in terms of what their bandwidth is, but we're not going to force you to do something in terms of what your bandwidth cannot. That's part of that rationale for open pods versus closed pods and things like that. So we don't have doses sitting together. We have multi-dose vials. We have difficult presentations for storage. We got a lot of variability in terms of the logistics of how to do this, which inevitably comes down to, okay, then we got to have open pods. We got to set this up with the quantities that we have. And then as we move forward, we need to be transparent in terms of how we're opening things up and what we're doing so that everyone can see and whether or not you agree with it or not, that totally understand, but at least you can understand the strategy of why we're trying to do what we're trying to do.
That's great. Here's an interesting question. This is from one of our larger corporate partners, asking if the state needs volunteers for the COVID vaccine call center. And if you, I understand it goes through 211, but there's actually a specific group that's handling those calls. And if you need volunteers, who can they potentially contact?
First, let me say thank you very much for the question. I think one of the things that I've been most impressed with, I'm a New Hampshire transplant. I've been up here with my family for the last 4 years, and I've been very impressed with New Hampshire's ability to share resources and try and problem solve in multiple ways. So I just want to extend a personal thanks to all of you who are looking at volunteering and trying to help out solve the solution in whatever way you can. There is a couple of different ways to go about this. One, if that's a larger population, right? That's a look. We, TW, we can't stand up an open site, but we can provide vaccinators to a particular site or things like that. We want to gather that in, and that looks a little bit different than just volunteering one-on-one, right? So if you want to volunteer one-on-one, we can get Jim that portal to do that. But there's I think it's New Hampshire Responds or something like that. That's a very direct access. You can go through, they'll check your license, they'll check all that stuff, and then they'll put you into that pool of vaccinators. The second thing that I would say is if you have a facility where you're like, look, I can't do vaccine clinics, but I can spare 5 people on a rotating basis to help out at one of these open pods where you can do that. That I think is a little bit more involved in the conversation. And so the first things that I would say is that we need to gather that information and collect that. And so if you're finding that is the case, then the regional public health networks are one way to access this. The other way to access this, I think, and if Jim, if you're willing to, is also through you to say, look, we have these people that do that. The last thing that I'll say is I really appreciate that, and please understand that vaccinators right now, unfortunately, aren't our bandwidth challenge. It's the actual vaccine. And so I don't want to discourage people from volunteering because I think that we're going to transition, right? We're going to move forward in where the government side of the response slowly de-escalates and the non-government side of the response slowly escalates and takes over that. And so as we move through those two switches, those changes, we're going to have some variability in what people can do.
Great. Just another kind of logistics question that was asked early on. How confident are you that the computer registration system on Friday will handle the traffic?
Great question, and one of the things that we looked at very, very diligently and continue to look at. Right now, I believe the site can handle up to 200,000 users at one time. That being said, in my eyes, that's not good enough. And so we're looking to expand that capacity to 300,000 to 500,000 that can be on that site at that one time. So I completely hear what you're saying. I think there's pros and cons to directing all your traffic in different streams. It's easier for communications. It's easier for a lot of other areas, but you have to have the IT infrastructure behind it to settle that. So while we are gaming up and making sure that we open up that and recognize that that throughput is as large as that contractor can make it, we're also setting up a backup system with the same system that we've used so far. So the person would see the same form, would submit the same data, but it would actually be a little different in terms of the back end of that. And so we're setting up a backup plan for that, right? Always have a plan B. And so trying to come up with that and make sure that that's up and ready for us to go if for some reason the unexpected happens.
Great. I have a question from a primary care practice, and they say, don't we need patient permission to send this list to the state? And bottom line is, this is an extraordinary situation we see every 100 years. So what the state has set is a HIPAA compliant way for you to transmit that information. Again, the goal is to try to get these medically vulnerable patients that you deem, and again, that's how the system is really working. So just a reminder, look closely at HON 34B, which goes in. It has both the Excel spreadsheet and the individual form, but the state is relying on you as practitioners, whether you're primary care or a specialist, to identify these individuals who are medically vulnerable and to submit that information to the state. Now, the patient can decline it. They can get that information. If they get email from the state, they can always say, no, I don't do that. But no, these are extraordinary times. We're trying to do it a secure method. But to do it where you would have to get approvals first would slow everything down and be counterproductive to what the goals are, is to get those most vulnerable individuals to reduce deaths in the state through getting them vaccinated as soon as possible. So with that, is there an estimated window when someone can expect to hear back after completing their pre-registration? Well, and when we last took it, it was like 4 or 5 days. Is that still about the same time window?
Yeah, that's what we're gaming out right now, is about a 5-day window. Now, that being said, if you submit it today, it's 5 days from the 22nd, right? So that's what we're working through to try and do that. And Jim, just to let you know, I'm a few minutes late for my next call, so maybe I can take one more question, but then I'm sorry.
No, I think that's it. I think the rest are, I'll just do a couple wrap up, but again, thank you very much, TW. I'm sure that next week we'll have more questions once we kind of get through this initial wave. And thank you for your time that you've committed and the expertise and all the efforts that you and your colleagues are doing there at the Division of Public Health to make this happen. So thank you very much, TW.
Thank you, and please know, everyone, we greatly respect and appreciate your jobs out there. We know it's not an easy environment to practice in, and we really do appreciate everything that you're doing, and know that we are working nonstop around the clock to do our best to support you and make this effort as painless as possible. So thank you all. Look forward to our next discussion. Bye-bye.
Thanks, TW. A couple quick wrap-up kind of questions that I think I can handle. If you emailed the information, uploaded the inpatient information, actually there was a correction from HON 34. So HON 34 went out Friday night. That was corrected by 34B. And the difference is they switched it to a secure FTP site that's now up on those documents. So again, if you send it to an email, the email that they recommended, you probably were thrown right into the VAM system. So don't do that. Submit that information securely up to the FTP site that's listed on those documents, and that'll ensure that the state gets it. Finally, just know that this session has been recorded, and the slide deck that we'll have will be available, and we'll start publishing those on the Medical Society's website on a regular basis so that you can go back. If you're a physician or a PA, then you know that that information comes out on a biweekly basis. But if you're others outside of that window, then we'll publish that information so that you can have, and the address is www.nhms.org. Again, nhms.org is the website. And we'll probably have that information posted up for the recording of this, and slides and other information. We'll have that up on our website later this afternoon. So again, thank you very much. I'm sorry if we didn't get to your question. We'll try to look back through them and stay open to see if I can address some of these questions directly to you. But again, thank you for your time. But we've reached our hour, and we'll look forward to seeing you next week. And thank you for all your efforts helping us fight the pandemic and get as many individuals vaccinated as possible. Take care, all.